Good morning. Today we are exploring electrical cartography, a clinical framework designed to help us navigate the complex world of ventricular arrhythmias. We will move from the basic molecular mechanisms to advanced target interventions used in modern electrophysiology. There are two primary ways these arrhythmias are born. First is focal automaticity, which arises from a specific point in the myocardium or Purkinje cells that begins firing abnormally. Second, and more common in diseased hearts, are reentrant circuits. These require a region of fibrosis like a scar from a prior heart attack, where slower conduction through damaged pathways creates an infinite electrical loop. Regardless of the mechanisms, the hallmark of a ventricular arrhythmia on the ECG is a widened QRS complex greater than 0.12 seconds, because the signal travels more slowly through the myocardium than through the heart's natural fast conduction system. We view these events on a spectrum of severity. PVCs, premature ventricular contractions, are isolated wide complexes that typically carry low clinical danger. Monomorphic VT shows identical QRS complex indicating a single origin endpoint, but carries a high risk of syncope. Moving into critical territory, polymorphic VT features a continuously changing morphology and often degenerates into ventricular fibrillation, VF. VF is the most lethal, presenting as chaotic irregular activation that is often driven by ischemia. We can use the ECG to map where in the heart the arrhythmia starts. The crossover rule tells us that an origin of the right ventricle or septum creates a left bundle branch block, LBBB, configuration in lead V1. Conversely, an origin in the left ventricular free wall creates a right bundle branch block, configuration. We also use the frontal nexus. If the inferior leads point down positive, the origin is cranium. If the point off negative, the origin is in the inferior wall. There are specific patterns we must recognize immediately. Torcida points is a polymorphic VT characterized by a twisting of the points around the baseline, usually occurring due to QT interval prolongation. On the other hand, sinusoidal or ventricular flutter is a very high-frequency, smooth VT where the QRS and T waves become indistinguishable, indicating massive conduction delay, often caused by severe ischemia, hyperkalemia, or drug toxicity. Symptoms range from mild palpitation to sudden cardiac arrest, with syncope being a major red flag, indicating an imminent risk of arrest. We must also be aware of the pseudo-bradycardia illusion. In cases of bigeminy, a premature beat may fail to generate an effective pulse wave. This causes the patient's palpable pulse to appear erroneously halved, potentially leading to a misdiagnosis of bradycardia when the underlying issue is actually a tachycardia. Our diagnostic steps follow a logical progression. Step 1, 12 lead ECG to look for signs of silent MIs, Q waves, or genetic syndromes. Step 2, an echocardiogram to assess ventricular function. Step 3, cardiac MRI with gadolinium, which is essential for identifying latent gadolinium enhancement, LGE, the specific regions of fibrosis that sustain VT. Step 4, evaluating the history and context, including key T prolonging medications and family history. Advanced mapping technology allows us to identify the danger zone, while an MRI identifies the physical scar. 3D electroanatomical mapping identifies its electrical consequence. We look for the border zones between healthy tissue, high voltage, and dead fibrotic scar, low voltage. These border zones contain the viable channels of slow conduction that sustains reentrant VT. Treatment follows a pyramid structure. We start at the base with trigger modification, removing aggravating factors, then move to suppressive pharmacology. If risk remains high, we provide an interventional safety net with an ICD, and finally, we aim for substrate elimination through catheter ablation to physically destroy the reentrant circuits. Our pharmacological tools include beta blockers, our first line for exercise-induced VAs, and calcium channel blockers for select idiopathic cases. We use sodium channel blockers, class 1, to reduce symptoms in ICD patients, though they carry risks in structural disease. Potassium channel blockers like sotalol can reduce ICD shocks but carry a risk of inducing torsade points. Here is the heavyweight amiodarone toxicity. The amiodarone can be toxic for the nervous systems and eyes, lungs, liver, thyroid, and heart. The ICD logic tree. So we have the detection, transvenous or subcutaneous ICD monitors rate and rhythm constantly. It can be detected monomorphic VT or a rapid VT, VF, or ATP failure. So if we detected an VT, we have to take an action and put on an anti-tachycardia pacing, an ATP. That's a device that delivers a rapid sequence of painless electrical impulses slightly faster than the VT to overdrive and terminate the circuit. With rapid VT, we need a high voltage shock. Delivers a painful, immediate defibrillation shock to reset the entire myocardium. So we have the ICD and catheter ablation. The ICD is the safety net. So our goal is terminate lethal arrhythmias, prevent sudden cardiac death. The limitation does not prevent arrhythmias from occurring, but prevents shocks-induced trauma. Frequent shocks-induced trauma. Indication: structural heart disease with greater than 1 year survival expectancy. The catheter ablation modifies or destroys the arrhythmogenic substrate to prevent recurrence. Its limitation is a complex procedure with risk of mortality in compromised patients. Indication: recurrent VAs, frequent ICD shocks, or highly curable idiopathic VAs. Ablation utilizes radiofrequency currents to produce controlled thermal lesions via resistive heating. So we have targeting the idiopathic, targeting the scar, and the frontier. The idiopathic is in structurally normal hearts. A small focal point is target. Long-term freedom from arrhythmia is excellent. Targeting the scar. In structural disease, wide areas of low-voltage fibrotic tissue must be mapped and ablated. For deep intramural scars, innovations like needle catheters and stereotactic body radiation therapy are emerging. Thanks all.